It's Charles Guttridge. I'm a SNOMED, what should I call myself? Engagement lead. Sometimes I call myself clinical lead. And that's because I still work in a healthcare organization in East London as the Chief Clinical Information Officer. And I'm sort of the eyes and ears for Ian Green, who's your other partner here, of what it's like to be actually on the ground, trying to run a hospital and make systems work for people. And so we work that patch regularly. And I'm personally looking forward to this session a great deal, because I think this is about me in my hospital trying to persuade the doctors and the nurses and so on to record data in a systematic way without leaving too many gaps. And that's, I'm sure for those of you who do the same sort of thing, a massive and never-ending task. And the story here, though, is that data then has to move somewhere. It has to be used either for commissioning purposes if you're in the UK, and that's what we call billing. And so that's directed off somewhere. It's obviously also used locally for quality improvement exercises, the audit of clinical care and so on. And then we wrap it up in all sorts of ways to be sent elsewhere, either to specialist societies, national bodies, into registries of one sort or another. And I think the history of registries is a bit tortured, personally, by folk like me, who years ago invented a way of collecting data, often onto a piece of paper or onto an Excel spreadsheet, and then looking at a data person saying, please turn this into something really cool for me to use that everybody in the country can use. And they look at you with a bit of surprise and say, well, that's not easy to do and we're not doing it today. But we have 4 speakers today who are going to translate what they've done in their jurisdictions, whether that's across a specialist society, across a European group, and so on. So I'm going to stop at that point, hand it to Ian to tell you how the tech is getting on, and then we'll start.
So the techies are getting on, well, the in-house techies are getting on really well. The outdoor techies, I think it's a train crash, but there we go. Anyway, whatever. So this session, as Charles just said, we're focused on clinical registries. There are 4 presenters, one of whom is pre-recorded, so you can watch the presentation here. Then we'll take questions from the room and also online. The other 3 presenters are amongst us. Sounds a bit dodgy, doesn't it, really? And we'll come to those as we go through. So obviously, you know, they'll do their presentations in person, and you can ask them questions accordingly. So I'm assuming we might have, I'm looking at Chris here, who's not looking at me. We have a video. There's no sound available. Okay. So, okay, this is, so Ronald, my man, how do you fancy presenting?
Sound?
With sound. Well, with sound, because you'll be here, because we haven't recorded you. That would be really good, because I know you're good. You might need your coffee. Yeah, I'm thinking you might. So the podium is yours, and I do believe, have you got your clicker? Yeah, it's good.
Nothing first.
Can you see?
Okay, so I'll just fast forward to the second presentation. Then we can go back to the rare disease registry. But please, mental note for you, keep the rare disease registry in mind. I will have a short link to that. Mike's not on. No.
Mic is on now, so even more sound. So pleasure being here on this session on, well, the clinical registries. My name is Ronald Cornet. I'm an associate professor in medical informatics at Amsterdam University Medical Centers, location AMC, which is in the Netherlands. And I'm presenting, well, also on behalf of Vianda Stel. She's also an associate professor in our department, and she's the managing director of the registry of the ERA, which is the European Renal Association. And I'll explain a bit about that to start with. And then further on, I would like to share with you our experiences on, well, collaborating with the SNOMED organization throughout the years in dealing with the coded information that we like to capture and have been capturing for a long time in our registry. So, well, it's the ERA registry on dialysis and transplant patients. So you can imagine throughout Europe, there's a whole bunch of countries, and each of these countries, they do their best to provide proper care to transplant or to kidney patients, either by providing them with dialysis or by performing transplants. And the European Renal Association Registry is there to try as much as possible to gain insight in the care being provided, in the success of that care being provided, and tries to learn lessons from that care so that countries can improve by basically learning from policies of other countries. So here we see a map of Europe. And we see countries in two colors, and that is because being a European registry, we have long ago decided to rely on national registries, and the national registries collect the data from their renal centers. And then there's two modalities. One is that countries or national registries provide individual patient data, which is shown here in red. And the other is registries that provide aggregated data. So they largely provide the numbers of patients. And well, what we see here is that the larger part of Europe is covered, but well, we're still working on covering all of SNOMED. I think that's one of the things we have alike with the SNOMED organization, trying to get full coverage. So you see a whole set of countries that provide individual patient data, and also quite a few countries that provide aggregated data. So when we talk about providing data, it is really a core data set, and this is what we start from. So there are also special studies, and there are affiliated registries like a pediatric kidney registry. But overall, basically the common ground that all of these registries provide as information are patient information and so-called event information. So, well, really you could say the core of the core: patient identifier, month and year of birth, gender of the patient, date of first ever kidney replacement therapy, that's what KRT stands for, the primary renal disease, so and that's one of these codes that we are collecting, and whether a patient is a resident. Being a European registry, of course, we sometimes have patients going throughout Europe and getting their care in another country than where they are a resident. And well, I will not go into details on patient record linking and knowing what happens if patients move across Europe, but well, that's a challenge in itself. And then on the events that for a patient, we keep track of, again, the patient identifiers, the date of the events, the order, and the type of events. And you can imagine a patient, of course, goes through these, well, phases of evolvement. So kidney disease can worsen, a patient can get modality change, go from, say, peritoneal dialysis to hemodialysis, then get on the waiting list and ultimately get a renal transplant, maybe has a graft failure and goes back to dialysis again. So all of these events are collected, and if the event is death, then we also collect the cause of death. And that's the other code where SNOMED comes into play. So I said some countries provide individual data, some countries provide aggregated data. And if they provide aggregated data, here we see a little summary what they would provide. And basically it's Excel files that they provide for each of the countries. And for these, we have no follow-up data and no cause of death codes. So this is really to have the crude figures of kidney patients in those countries. And here you see a couple of analyses, the kind of things that we can do with the data that is provided from throughout Europe. The number of incident patients accepted for kidney replacement therapy as of 2021, and the incident patients accepted for kidney replacement therapy at day one. And on the left, you see it spread out per, and I think it's very small. I find it hard to read. That's that's the I as far as I can tell, the primary renal disease, and that's age groups, unadjusted incident. Oh no, on the left it's the countries, and on the right it's the various types by age group. So this is all the kind of distinctions that we can make. And of course, we can drill down further, but this is really the high level statistics that we start from. So what's our approach to data capture? Because, well, I said we are a European registry getting data from national registries, getting their data from the renal centers. So the idea is that the centers provide, and through the registries, a limited set of values to support, well, what we ultimately would like is support the clinical data capture practices, to support the registry data provision practices, and then what we do, the analysis at the national and European level. So the challenge is, how do we prevent that there's a lot of, well, manual labor in getting these data ready for clinical centers to provide to registries, and maybe also for registries then to provide to our European registry. So focusing on the coded items, we have been working on the primary renal disease codes. They have been defined, and then we subsequently mapped them to SNOMED CT and ICD-10. And for the cause of death codes, they need to be, well, redefined with the intent to map them, and whether that's subsequently or upfront, to SNOMED CT, that's a discussion. And then also have the mapping to ICD-10, ICD-11. And well, as you see, we have one and we need one. So what I would like to do is show you what we have, and what we learned from that, and how we are now together with the SNOMED organization trying to, well, implement the cause of death values in such a way that we benefit from the lessons that we've learned. So first, why would we use SNOMED CT? Well, because there's a whole bunch of usage scenarios that we would like to be able to support. And that's also a thing that we need to take into account. Europe is still highly diverse. So there are sites where there's still a matter of paper data capture. There are local homegrown systems which may poorly integrate with, like, the national registries. But there are also cases which are much more elaborate, which have more standardized systems, which can automatically or semi-automatically provide their data to the registry system. And even the level of registries differs. So the variety of registry data provision is also large. And well, it gets less and less paper, but it's still there. Some registries require manual input of the data, talking about redoing the work. And of course, we try as much as possible support the extraction from clinical systems. And well, we would really like to work towards being able to make this data really flow from source to our European registry. And that's the things for which we're also looking at what SNOMED can do for us. Well, what have we in terms of the primary renal disease codes? There are 284. And I don't know if any of you does maintenance of whatever value sets or reference sets, and you can think, oh, that's a small one. But, well, even then, we stumble upon the challenges. So what we have done, we captured those primary renal diseases. We specified the diagnostic criteria, as in when do we consider a patient to have this condition, and done SNOMED and ICD-10 mapping. And we developed a tool so that clinicians throughout Europe can search for their primary renal disease codes. And that's all available in English. And some countries have made translations of especially the diagnostic criteria, so that it helps clinicians to, based on these criteria, select the proper code. So, well, we didn't get there in a single step. And actually, this goes back almost 30 years. When we started running the registry in Amsterdam, we took it over from elsewhere. There was a coding system in place developed in 1994 or even before and updated in 1995. And we see how we have the primary renal diseases with codes 10, 11, 12, etc. and being grouped. So you see the first, well, about 10, they go in group 1, then we get group 2, which is the pyelonephritides, and well, more groups to follow. In total, it was only 65 codes, and it was experienced that, well, for any clinical relevance, there was a need to expand the code set. And I think that's a constant in anyone developing a set. I always hear people say, oh, I just need 20, I just need 50 codes. And before you know it, you have a couple of hundred. And that goes for us as well. And so actually, interestingly, these codes have been in SNOMED CT until 2009. It was developed in England, so it got aligned with the read codes. The read codes merged with the clinical terms, and we can see, and ERA used to be also together with the European Dialysis and Transplant Association. So they were all in SNOMED, but with this associated with renal failure suffix. And then it was decided that, well, these were odd ones out, and it would make sense to retire them, which happened like 15 years ago. So you could say already by then we had our alignment and collaboration with SNOMED. But then a couple of years later, as I said, these 65 codes were considered insufficient. So by 2012, we released an updated set with, well, over 200 cause of death codes. And in 2017, these were provided as a so-called free set of primary renal disease content for use in the renal registry. And you see how this alignment and collaboration was announced by then. So this is how we got to the collaboration on primary renal diseases. And in 2019, we did an update, and again, with the involvement of SNOMED CT. And that means that ever since we are in contact, because sometimes we get requests for updates of the coding system, and sometimes SNOMED changes, and we need to see if those changes are properly reflected in our set of primary renal diseases. So what did we learn? And I think we're still learning. I think one really important benefit I saw in this collaboration was the quality aspect. And then I mean the quality of the codes. Because You work with clinicians, you come up with a great set of codes, and we're all very happy. And then we try to get that aligned with SNOMED. And well, I say this in many places, and not just here because I'm at a SNOMED conference. I've been impressed by the editorial processes of the SNOMED organization, the speed and the skills and knowledge that are provided in doing so. So it was really pointed out in saying, oh yes, but you have these two descriptions, but they are synonyms, so they shouldn't be two codes. And then we go back to our nephrologist saying, hey, they say that these are synonyms. Ah, they're right. Or they disagreed, and then we would, well, try and resolve, and maybe it wasn't a synonym, and then we would add a concept to SNOMED. So it was removal of duplicates from our list. It was addition of synonyms sometimes to SNOMED CT, and in a few cases, addition of concepts to SNOMED CT. Things that you stumble upon and think, hey, if this should be here, then that should be there, but that's missing. And so it is basically a mutual quality improvement process. So I think that is really valuable. And then, as I said, it was released as a free set, meaning everyone can use it. And we see here an overview. There's a few other free sets, International Patient Summary, an IHE free set, and one on DICOM. So this means that in the nephrology world, people could work with these codes if they would want to, which of course primarily makes sense if they have their source data also using SNOMED CT. So a challenge, I think, is the maintenance effort. There's work on this for the SNOMED organization to indeed run a few tests against the free set and see if there have been changes impacting the free set, and the communication with us to resolve those changes. So changes impact the free set, and there's the manual assessment that we need to do periodically. And well, you get the things like updating upcoming ICD-11. Well, we're now mapped to ICD-10, so we have to do that mapping one way or another. Maybe we get it from SNOMED, then that's great. I see Jane nodding. So all of these things, I think, and the whole process of establishing this list, provided us with insights that it helps so much to establish that quality, but it still provides quite some maintenance. So the question is, what can we learn and how can we do that better in the next cause of death? Because now we have cause of death codes, and again, really a small number, only 55, available in English, and some countries have translated them again for their clinicians to be understandable. But like with the primary renal diseases, there is a request to revise, to expand. So now the question is, and I will not ask you for advice, but our question is, okay, so now how are we going to move that forward? Because, well, we could go in this like Delphi process and collect the codes that we want to implement. But, well, if we first look where we would want to get, well, we want to get at a redefined list of cause of death, because some are outdated, some are never used. So we need to revise that. We want close linkage to SNOMED CT. We want to, for ourselves, be as clear as possible on things like diagnostic criteria. We want, it's always interesting, you call it cause of death, you think diseases and stumble upon things that aren't diseases. So there's non-disease codes that we would, or causes that we would like to include. And well, it may be that there are things needed for which, again, there's no SNOMED code yet. So what we want to do is to align as closely as possible to SNOMED, so that by then, again, we benefit from having ICD-10 or ICD-11 mappings. And we would like to establish a cause of death searching tool, similar to what we now have for our primary renal diseases. And I think it's great. I said it a few days ago. I remember when the SNOMED organization started, they said, well, we are we do deliver content and we stick to delivering terminology. And if I see now the set of tooling that has been established, I think that is really impressive, including all the demo materials being provided, like the demo electronic health record in which you can enter information and things like that. I think that is extremely valuable. And I think we need to really collaborate closely and see that we create a user interface, so a slightly different topic, but a user interface with which we can capture these coded data as well as possible. So, and I think there's a lot we can benefit from what is there in SNOMED currently. So we want to establish jointly a set of relevant cause of death codes aligned with SNOMED CT. So currently we are having, well, initial rounds of discussions with clinicians going through these codes, going through their needs, and also at the same time raising their understanding of what SNOMED CT can and cannot offer. And we see that is really an area where we, well, have to provide education. So, and ultimately, when we have that, I think we again get to the challenge, how can we deliver this in all countries in the whole spectrum, as I said, from like paper-based to the well-integrated systems. And yeah, so how can we work with that? Can they do clinical data capture using SNOMED codes if they are not yet a member? I know in Europe, it becomes an ever smaller problem. That's great. I know the outside world likes to use this as an excuse and say, oh yeah, but SNOMED is not an open system and there's license fees. And I can come up with all the yes buts, but I think it is really, really important that we can, one way or another, take away that either fear or skepticism or whatever it is, so that we can really embark on applying SNOMED broadly without having to worry if a non-country member would like to join an international effort as this one, that can be done. Because I didn't mention, and maybe it wasn't shown on the map even, but when I say Europe, it's actually also a few countries bordering the Mediterranean. So there is already some expanding there. And how can we make sure that we can do that properly and educate people on the possibilities? And then we need to also educate registries, because they are often so used and, well, really grown into homegrown systems that if you want to have them move to a system like SNOMED, you would also have to educate the national registries, because otherwise we can't get them to go along. And that is work, I think, for us all to do. And then we can do the analysis at the national and at the European level. And of course, given all, well, expertise and licensing that has been arranged, I think that is really where the power is. And well, in this process, what we're trying to achieve is to really minimize the maintenance. I think Jane and others will like that. I'm sure we will like that, to make sure that whatever set of cause of death codes we have, that the maintenance is as easy as possible. Because as they say, it's not for Christmas, it's for a lifetime. And you need to be willing to invest in that. So, and maybe as an outlook, and I know we're in the US here, so not all of you may have a clear picture of what's happening in Europe. Well, even many in Europe don't have that, so you're excused. Or can piggyback on my explanation. So we will work towards a European health data space. I should add to that regulations. So there will not be some humongous system, but there will regulations that contribute to establish a likely federated system in which data can be made available for providing healthcare and for doing research. So those regulations will contribute towards a broader data availability. And well, if we talk about this broader availability, it is important to realize that there are many stakeholders which are involved in the use of data. The regulators, insurers, the European Medicines Agency, and increasingly the patients. And for all of these stakeholders, there is a need for ready-to-use data. And also, especially in the clinical arena, there is the need, for example, to be able to do clinical decision support. So we need to have well-established codes. And now back to the rare diseases, it is important to realize that a patient is not only a renal disease patient, but patients are often multimorbid. But even if a patient has one condition like a papillary renal cell adenocarcinoma, it's a kidney disease, so it would come to our ERA registry. But it's also a carcinoma, so it would require an ICD-10 code for maybe a cancer registry. And it's a rare kidney disease, so it might go to ERCRAC that Frans will hopefully shortly be presenting, who have developed a data dictionary in which this data lands. So it is not just saying, oh, it's just this one ERA code that we need, so please, clinicians at the source, provide us with this code, because all of these parties ask for these codes. And we really need to work towards getting away from proprietary codes or having those codes really closely interlinked with the SNOMED codes so that we can really make this move forward. And with that, I really like to thank you for your attention, and I'm happy to take any questions.
Thanks for that, Ronald. Brilliant. And a great start. And I think is a great example of the sort of problems that I described at the start of how you get from the individual clinician to this kind of thing. So there's one question online, which is comes from Stéphane Dubois, who says, are all the primary renal disease codes in the registry mapped to SNOMED now?
They are, yes. So this the current primary renal diseases that we are working with and that are being provided by the registries are all mapped to SNOMED.
Great. I'm going to ask a question while the others just consider their questions. Can you just let me know if there's been any patient involvement in the development of the registries?
I couldn't really tell that. I can only tell for the ERA registry, it has been existing for like over 50 years. We do have the collaboration with national registries, and I think the national registries, they often, like I know at least for the Dutch registry, they have a link to the Dutch Kidney Patient Foundation or whatever they're called exactly. But if you talk about maybe, would it be FPA or a European Patients Federation? I'm not aware, but it doesn't mean it's not the case.
Jane wants to give you help in
There's just 2 points, because I know there are important people in here who want to ask questions. 2 points. This will be part of the free set. So the question about whether people can access it, it'll be available once it's done. The other thing that Viada asked me was, did we have any cause of death data? We don't hold that, but does anybody else have it that they can share it with the project? Because as Ronald's already said, they are looking at what that cause of death set looks like, and they asked me as a starting point. So if any of you've got some, can you let me know, and then I can pass it on to Viada. Okay.
Yeah, thanks for adding that, because indeed that is an outreach to the broader community that we want to learn, and we can reinvent the wheel and think about. Actually, I was looking into the suicide example, and it's already somewhat challenging. Is then cause of death a suicide attempt, or, well, etc. And I think anything we can learn from that, and any way in which we can reuse any resources would be of great help also for further interoperability.
There's a question from Jim. Jim, you need to keep it quite close to your mouth in order to make it work. And can you tell us who you are?
Hi, Ronald. I'm Jim Campbell from the University of Nebraska.
Pleasure meeting you, Jim.
And one thing we share across the oceans and pretty much worldwide is that our countries are obliged to report their cause of death data in a classification, ICD-11. And when we did the mapping to ICD-10 project, some years back, one of the problems with classifications is always that there's, sorts of things like clinical context and encounters and all the rest built into the classification for their accounting purposes. And we found that mapping was, in other words, mapping to a discrete set of SNOMED codes was actually a sort of a complex issue. I'm assuming that that's something your countries deal with in terms of reporting the ICD-11. So have you been doing any work in that area in terms of creating a reproducible protocol for identifying the SNOMED codes that are relevant to a particular ICD-11 class?
That's an excellent question, which I will take as a suggestion to do. So the answer is no. No, because we are really just starting, and so maybe you may also think, so why would you need this anyhow if you have your ICD codes? So the question is again, or the rationale is again that there is a need for a specific focus on renal causes of death. And we need to see to what extent that is covered by ICD-10/ICD-11, and or where we need to be able to drill down further. And that is why we want to rely on working with SNOMED as a starter. And if we get the ICD codes for free, then we can define the focus and see if the extent of the ICD-11 to look forward is enough, or whether still more is needed. But I think getting really clear what we need and how that relates to the other system is a very important part of this procedure that we have to describe. Yeah, thank you.
I have another question here, just to remind you to tell us who you are. Or do you want me to introduce you?
Okay, I'm helping you. Thank you. This is Mohammed Al-Shihri from Saudi Arabia. Thank you very much for this informative, presentation. And we are sharing the same issues, especially with the registry and data collection. I have actually some question, but maybe the most important one is with regard to your experience with those providers who are having a paper record. What procedure you are using to collect the data from them? And the other question, what type of data you are collecting? So, I mean, are you collecting like radiology results? Are you collecting? Because I think one slide you're using DICOM, so I would like to find out.
Yeah, so regarding your first question, I think that's indeed an important and challenging issue that we want to capture or cater for all cases from indeed paper-based to the, full-blown electronic health records, which are already fully semantically interoperable. If anyone knows one, let me know. But indeed for paper, so what we do now is basically, so we have that lookup tool so that you can search and then find this 3-letter code or 3-digit code or 4-digit code that you can then report as a cause of death code on paper. Well, actually, what we learned from SNOMED was to add a check digit. As you saw the old numbers, it was just 10, 11, 12, and sometimes it would be hard to read or tell an 11 from a 17. So we add check digits to also cater for that. But you want to be able to have really short codes that people could indeed write down and get from a system or maybe from a leaflet with 250 codes on it, small print. Or have the tool or a similar tool integrated into a record where you can pick one from that is stored right away. So that's how we try to cater for those various scenarios, by really having short codes and not have to write like 12 digit SNOMED codes. And about the data that we collect, well, the core data set is currently very limited. So we don't do any radiology, things like that. But we sometimes have special studies in which we collect other data. Plus, there are other initiatives. I'm also involved in a renal pathology project, or a renal pathology codes project, which then again would relate, of course, I would say, to all this capture of renal data. So it doesn't stop with this small renal data set. It does link to other domains. Thank you very much.
I don't see any. I do see another hand. Inge, tell us who you are.
I'm Inge Soons. I'm a terminologist from the Netherlands. And so it was released as a free set. Is it a part of the global patient set or is it a distinct set?
It's a distinct set as well.
Okay. And so would that be an approach for other registries as well? Let's say if the pulmonary disease European registry would want this. Is that possible?
They know where we are. Come and talk to us.
So
I take that as a yes.
Yeah, you heard it here. Spread the love. SNOMED is everywhere. If there aren't any more questions, it falls to me to thank Ronald very much. If you're staying, Ronald, maybe over tea, you can ask him additional questions and so on. And as we build up the picture of how registries are built, how they're developed, how they're used, I think there's a sort of expanding set of questions that we all want to play into. It may not be this afternoon, but this is a really important part of saving lives, actually, because as you saw from the data that Ronald did show, the outcomes for people with renal disease vary incredibly across different nations and so on. And there must be clues as to why that's happening in the data that we can use to make lives better.
And going back, going back to your point, the key thing is, and Ronald, I was delighted you had that on the slide, was that a patient with a renal disease often falls into more than one registry. And what we tried to do this a few years ago, starting with cardiac diseases. We didn't get very far, but a renal person could be on a diabetes register. They could be on a cardiac register of some sort, as well as a renal. And the key thing is collecting the single items. So let's try and standardize the items where we can across all the registries. That's why we're holding today, really, isn't it? That's where we'd like to get to. So, yeah.
That's great. So please raise a hand for Ronald. Thank you
very much. I'll be around.
So thank you very much, Ronald. For those that are online, can I just remind you, if you've got questions, pop them in the Q&A box, which is at the bottom of your screen. Now I'm going to ask a lovely lady from the Netherlands to come and talk to you. So Sylvia, I do believe your slides will magically appear on the screen.
I hope so. Because otherwise I'm going to tell a different story, I guess.
Once you do the clicker. Well, you could be telling anybody's story, right?
Oh, we have a
Forget
break?
about the refreshment break. We'll come back to that in a minute. You're not getting coffee that
wait,
quick.
other direction. Yeah, that's me. I'm not from Nictus though. I will introduce myself and I'm going to rearrange this a little bit. So
Do you want me to come and give you a leg up?
I think, can everyone hear me now? Perfect. Yeah. So hi everyone, I'm Sylvia van Laar. I'm yeah, this is better. I'm from the Ministry of Health at the moment. I started there in December. And I'm trained as a pharmacist, so I'm happy to be in a clinical session this afternoon. But I did research how to capture data to use that for, to investigate cancer medicines in practice. And I'm very passionate about how can we use those data from the health records better. And that's why I transferred after my research to the Ministry of Health. And today I'm gonna talk about two things, SNOMED and also the Dutch clinical information models. And as I said, I'm not the one who makes everything. Then I need to look, for example, at Inge over at Nectis. So if you have very detailed questions, I cannot answer them, but I can tell the story and the struggle we have making policy about this topic. And I'm gonna try. Yes. So I'm gonna talk about a few points, and it will guide you through the story relating to the registries. So first a bit, how does the healthcare information system actually works in the Netherlands? What are those clinical information models? And then SNOMED related to those models. Then registries, primary care, and then finally those clinical information models for registries. It's a whole path, but I will take you through it. So first, our Dutch healthcare information system is, even a small country, but it's quite complicated because we have a free market of healthcare systems, and that means there are a lot of different suppliers. They have different products they use. So we need a way to make it interoperable because that's how we can share data in the end. So luckily, we have colleagues who made a very nice vision towards 2035, which is far in the future, to make a national healthcare system that is integrated, where data is available, it's a network, it's organized. Terminology is a part of that. But as you can see, we're still in 2023, we're just in the beginning. It's going to take a lot of tiny steps to get to the endpoint. And to get to the interoperability and intraoperability, you might know this picture, and it's very nice to explain how we look at it. It's also from Nectis, our nice colleagues. You can organize it in a lot of layers: the infrastructure, the interfacing, the structure and semantics, collaborations, and the policy alignment. And as you all might know, we're going to talk about the layer on the information. And the semantics, it will not surprise you. The biggest dot of the ones we're going to use is SNOMED, and we're going to, our policies are focusing on to move the use of SNOMED and to improve it, and how to make sure all healthcare providers can implement this. And this is one of the things we're now focusing on, next to LOINC and the IDMP. But only SNOMED is not enough. You need something you want to communicate, something you need a structure. At least if you want to communicate between those different healthcare informations. We said as the Netherlands, okay, we can make agreements on what we're going to exchange. So that's what we're going to make a structure around. And these agreements were designed already more than 10 years ago. And time continues, and we're developing into a more interoperable world. It's a very difficult word. And those clinical information models are actually just agreements on very specific medical concepts. What do they include? And everyone agrees. And with those, we aim to standardize the information around the care process if we're going to exchange it. So this is what it looks like. For example, this is for the examples around a problem, a healthcare problem. As you can see, it has a lot of concepts, and it also links to some lists, some code lists. And you can see on the left, on the bottom, you can see a problem name code list. And this is a code list. Well, all the code lists include some codes. And this one still includes several code lists. As I explained, we still don't use SNOMED for everything, but that's in the future, maybe, hopefully. But we have some code lists also in disguise that use SNOMED already, which is very useful. And this is the one on top. It's the one that includes diagnoses. It's a thesaurus for diagnosis in hospitals, and it's uses SNOMED, and it has lists per specialism. And on the right side, you can see an example of that. And from this code list, there's mappings to the ICD-10, to a code which is used for financing, and also a code used in intensive care. And only having this is already a basis which is used in some registries, which I'm going to make some nice sidestep towards. For example, the Apache mapping that is used in our National Intensive Care Evaluation Registry. And this is a registry, for example, if you think of COVID, has a really high importance that you can see what's happening there. And it's used, for example, for benchmarking, for shared decision-making, and also can be used for research. And as another example from the National Neonatal Registration, there's a registry on congenital diseases. So if a patient, if they leave the care, there's very nice that the primary registration can automatically be recorded into this registry by discharge. And also the purpose of this one is obviously to improve the quality of care. So then next to those building blocks or clinical information models I've been talking about, well, this started more than 10 years ago, and in the meantime, there's more than 100 available. And this is a screenshot of those names, and it's a lot. But they all relate to healthcare data. And most, if there's code list, include at least SNOMED, and they are communicated by FHIR. And as I said, it's Dutch clinical information models, and we also use the term clinical building blocks. And that's actually how you can see them. You can stack them together and make your own data sets. But if you use the same concepts, then you can break it down and make a new one, just a little bit different house, but the concept stays the same. And that's actually a power of these building blocks. It's a challenge. And one of the things it is used for in primary care is a Dutch version of the patient summary, and it's built of a large set of those building blocks, as you can see. For example, the building block of the problem, which I showed you before, but also laboratory results, medication, mobility, a procedure. There's a lot in there. And this is a set we are focusing now on to make it obligatory to, if you exchange data, you can use this whole set. So how does it work? This is the summary. But in July 2023, so recently, we had a new act in the Netherlands implemented. And this act made it, how do you say that? Mandatory to, it's very nice to have someone telling me what to say. Make it mandatory to exchange certain sets of data electronic. And there's two different types. You can say this set of data, you just have to exchange it electronically. Or if you exchange it electronically, you also have a set of rules you have to follow. So if you exchange it, you have to do it by this. You have to use these blocks. You have to include this information. And then in that way, we all can actually implement the data in the other system because we have agreements on what we share on both sides. And as you can see, there's already a list of sets of information. So the one on top is the one I showed you. And the orange block in the end is where we are aiming for to make it mandatory. So it's going to be mandatory to share it between hospitals to make it clear. And so we have some lists already in our, well, in the future, we're going to make mandatory to exchange data electronically with a specific set, including SNOMED, it's a long run, between healthcare professionals. And now you might think we were talking about registries, right? Why do you show me this primary care? But the good thing is, if we have those building blocks, you can use it for research, of course. So that is, luckily there's done some research in how we can do this by other researchers. And this is one example. Don't look at the table yet. I'm gonna explain it first. In a hospital, and the other in the Netherlands, they have they've changed their way they register the data around head and neck oncology. They switched to unstructured to structured. They made it possible to map the data to those building blocks. And from those building blocks, they could potentially go to the registry. And one of the things you want to know, which is actually in this table, is okay, but what does this add to the information, to the registry? And this study compared the data quality before the switch, so when it was still unstructured, towards after. And they looked into what is the improvement in the quality of the data actually. So what if we go to the structured way? And you can see the score, it's 0 to 100, and you can see the structured documentation on the right side. It's all higher than the unstructured documentation. So over time, by switching towards a different way of working, they can show, hey, this does not only make it possible to reuse the data, but also improves the quality of the data. So that's very promising. At least that's, for me, a reason to say we actually have to do this, not only to make it easier, but also for better care. And they also looked into what is the difference. So is there enough data, for example? Is it understandable? Does it address the address the issue? So this study for me shows if we are going to work in a different way, if we're going to register our information in a different way, we are improving data and make it possible to reuse it. And then luckily there was still another researcher who thought, oh, this is interesting. How can we go from those building blocks to registries? And she investigated how many of the registries we have. I think there's 30 something in this list. And what you can see in blue is how many of those building blocks already cover the information potentially in those registries. So light blue it covers it, the basic set. And in green, it's some other ones. So a little bit, there are also, and so you can see you have some future ones, and there's a little bit in red. But you can understand if you all start working in this way with using those blocks of information, how many work you're gonna reduce actually, and we can reuse the information. And for me, it's if you go to registry and say like, hey, you still have to document like 10-20% well, manually or in an extra way, it's so much of a reduction already. So that is, for me, is very promising. And there's another one showing actually which ones are included. So almost 20% is covered by the one I showed you, the problem. So with the diagnosis included, with the SNOMED codes, and then a procedure and something about the patient. So 5 of those blocks already cover most of the information needed in the registries. So what it shows, there's a lot of potential, but we are not there yet. We still have to, well, 2035, if we could believe the first graph I showed you. But this is very useful for me as a policymaker now to say, hey, this is proof. We need to move in this direction. It does not only help primary care, but also researchers, and that can, in the end, help primary care again. So this is my last slide. Some future perspectives for the Netherlands. In general, we're gonna focus on more use of SNOMED, not only inside hospitals, also outside hospitals. So for example, general practitioners. And in this way, we want to make data more standardized available, of course. And this is the first steps, tiny steps, but also big steps towards more interoperable data set for primary care, research, and also registries. That's what I wanted to tell you. And if any questions, happy to answer.
You know the rule, don't you?
I know the. Yes. My name is Marte Bø. I'm from the Norwegian NRC. Was that good enough?
Yeah, that's
Okay.
great.
Okay. This is really interesting. Thank you for a very nice presentation. I was wondering what kind of format or what you use for exchanging the data. Is it like HL7 or FHIR? How do you share the data in between the hospitals?
I'm also looking at my helpline over there, but we're moving towards FHIR. I'm not sure how much percentage is already covered by FHIR, but that's going to be the one that needs to be covering everything.
Thank you. Yeah.
Any other questions? No. What's that, Victor?
Hello, Victor Medina. I'm a surgical terminologist with SNOMED International. My question is about the clinicians. How are they adapting and adopting the structure register of their practice?
The one example I showed you, the clinicians themselves were very involved and actually motivated to improve this, well, change themselves. But this is actually a question I'm still struggling with. We're still like, how are we gonna indeed change it? It's part culture, it's part education, it's part changing the infra, well, the how do you say that? The health records. So we're not there yet. And there's a lot of training involved as well, just implementation and make them their own implementation rules and guides. So it's on one side, we don't have all the answers, and on the other side, it's a lot of talking and seeing which steps we can make already. So if you have a better answer or extra ideas, happy to.
Well, I'm from Mexico, and we're struggling with clinicians to adopt solutions, digital solutions. Anyone, any kind, they don't want it. And when you're talking about structured register of clinical information, there is a wall, and they close their minds and they don't want to know anything about it. And there is the change management techniques and things. But I like to call that change confidence. You know, change the confidence, give them confidence, and they will adopt whatever they need to adopt.
Yeah, and I think you should not switch like from one day to another. Say like this is your whole new world now. Just one step at a time, or one use case, and see if it works for them and make them indeed confident. And also, if they get data back that they can use, that might also be useful.
Sylvia, I hope you can take more questions. I'd like to ask one, then
Sure.
we've got one there and one there. My question is trying to reflect a bit on UK experience here. So I think it's fair to say that in English general practice, all general practitioners use SNOMED CT universally. That's all they use, as well as free text, but they do have very comprehensive problem lists that often actually have a 20-year duration. One of the things that I think made that happen was incentivizing GPs through something called the quality outcomes framework, which is essentially pay for code type of approach. So as long as you'd completed a local registry for your practice, showing that you'd collected things, you got more money. Are you thinking about that as a policymaker?
No, not yet. No, not yet.
Not yet.
No, but we have like, if they have an implementation plan and they use can use like nationwide plans to money to implement that, we can help, but it's not going to be like €1 for a code.
Hi, this is Monica Schragen. I'm one of Sylvia's colleagues. I actually wanted to elaborate a little bit more on your question because the struggle you have, we recognize that as well. So we have what we see in the Netherlands is that we have a very committed group of physicians that are very committed to the subject of making a change in medical informatics. But in order to do so, as Sylvia also said, this problem has, I think, a two-path solution, one of which is, in my experience, I'm a nurse from way back when, physicians like what they know, and they tend to stick with that, unless it's extraordinarily clear to them or made clear to them by experience that the change that we see actually helps them. So part of the solution is educating them, letting them see what the benefit is of using a standard like SNOMED. That's one part. The other part is having a clear perspective as a government. So what we see is not, in 2011, we had a proposition of making an electronic patient, electronic patient files, to have that mandatory all over. That didn't pass Congress, but then the healthcare field asked us to, let us have the reins in this. And then in 2019, they asked us to take back the reins because they couldn't solve the problem themselves, which makes clear that some government steering is necessary. So the other path of the two-path way is to have some clear steering from a government point of view. Where are we going? Why are we doing this? We're past the point of having discussions about whether or not are we going to use SNOMED? No, we're going to use SNOMED, and this is how we're going to do it. So we asked NICTIS, they're working on a SNOMED implementation advice for all the clinical settings. And then we're going to ask them to, okay, given that it is the standard we're going to work with, what do you need to get there? Give us some insight in what you need. And we're going to come up with the finances to support you in that decision. And then from that, get that change going. And then not forget, of course, that education, showing the added value of using a standard like SNOMED to have that process going. So that might be an idea, but clear government steering, having a clear vision helps them tremendously.
I'll say I agree with that.
Hi, thanks again about data collection. Also my question, as on overall, I think you have about 31 national registry. Am I right?
No, this was the ones included in the study.
Okay. So how many registries now you have as a national registries?
Honestly, I don't know.
Okay.
No,
Yeah, it's about 100. Yeah, okay. So my question regarding the data integration or the data collection. So as an overall, what's the percentage of data integration from the providers? So are you dealing with all providers who are submitting the data to you guys on like manually or like data entry, or like there is like a complete integration with HISs? You got me, or?
no, not
Okay, now I'm a hospital and you are the registry, okay? Okay, see, now, if there is like a hospital would like to push the data for you guys in the registry, are they pushing this electronically, or they are like using a manual entry and they put diagnosis, blah, blah, blah? You know what I mean?
Yeah.
Clear now, or?
Yeah, well, the fact is that they still cannot push everything just electronically.
Okay, so most of the work is done like manual data collection, let's say.
I don't know the actual numbers on this, but.
Is it clear the question for you? Or?
No, I don't know, but I've like, when I worked in the hospital, I was working also with doing study with like the people on lung cancer. And one of the oncologists was always complaining, oh, there comes the person again, costs so many euros, and she just sits there and types.
Yes,
so that's the image I have, and I'm not sure if it's for everything, but that's the only thing to steer on. So.
My guess is if it's anything like the UK, it's a mixture, and almost everything is uploaded electronically, but entered from one system to another by looking at two screens often. That's a very common model of data transfer, isn't it? Right, well, I think unless there are any other questions for Sylvia.
Can also come to me later. That's
okay.
Charles.
Oh, okay. He's got another question for you.
Great.
But remember what she said. She'd like to see you after school.
No, so I've got one question online from Vianda, who's Ronald's partner in crime, I guess. So great presentation. Thanks. Is SNOMED part of the education of the study of medicine in the Netherlands, or how do doctors otherwise know about SNOMED? So I kind of know the answer to this, but I'm going to ask you anyway.
Well, it's a question I also want to have the clear answer on. And no, but also like we're not only steering on the standards, but also the question, how are we going to improve the registration? And education is part of it. And where are you going to start the education? Is it like in the first years, or is it in the later on? But I do believe that it at least needs to be improved. To make sure, not sure if it's like specifically SNOMED, but if you use the health records, know that you, well, we're changing the future. Well, we're, how do you say that? The way we use the data is different than years ago, and that's what needs to be educated. So SNOMED can be part of that.
I mean, so this is something that, so Charles and I present on clinical engagements in a number of different venues all over the place. One of the things which comes up frequently is the idea of including, I'll call it SNOMED, but it's broader than SNOMED. So whether you're talking about SNOMED, whether you're talking about digital health, structured data, but to bring that into education at a very early point. So whether that's in medical schools, whether that's in nurse training, I'll say physio training, otherwise Jane will kick me. But to introduce the idea of it very early. So, you know, a bit like when you're teaching children, catch them early, so they say. I think the other thing, based on my experience, not necessarily as a nurse, but working with GPs in the UK, is if you want clinicians to change, there has to be a feedback loop. So where where clinicians, however it's getting in there, it's getting from clinicians into registries. If you're looking at improving the quality of registries, the quality of data going into registries, the only way anyone can do that is to work on the people that are recording the data. So you feedback the loop. But so it's a combination of everything, I think, in terms of how you do that. But it needs thinking through, because it needs in the old-fashioned way of saying it, it needs joined up thinking.
Yeah, thank you.
Do you want to add anything, Dr.? Oh, okay, that's one. Right, well, thank you, Sylvia. I think a round of applause is in order. So we're a couple of minutes early, so I'm going to keep you here. No, I'm not. I'm going to let you go to coffee earlier while we sort out some technical challenges. And I've got the guys at the back going, yes. So if we come back for 3:30, that would be marvelous. Please do come back, because there are two further presentations. One will be a virtual presentation, which is pre-recorded, on some of the registries, well, the rare disease registries in Europe. And my new friend here is going to talk about the registries at CDC over here in the US, both of which will be really informative. So please go and enjoy your coffee and come back, otherwise I'll hunt you down. Good afternoon from Atlanta. Right, so welcome back to the second part of the clinical session on clinical registries. So I hope you've kind of all caffeined up and you're all ready to go. So the first presentation is actually a recording. So Franz, I'll let the slides introduce him, but Franz is over in Germany. He's going to talk about EURIDIS, which is the European Organization for Rare Diseases. So really looking at all the rare disease registries and how that's operating across the EU. And hopefully this will work.
Thank you for the kind introduction. My name is Franz Schäfer, and I'm one of the coordinators of a European reference network for rare diseases. Actually, I coordinate the one for rare kidney diseases, but there's 24 of us, 24 thematic networks were formed by the European Commission in 2017. So we are covering basically all the different facets of rare diseases, and we are covering a large proportion of these patients in Europe that are seen in our reference centers. We have now 1,600 specialized units collaborating in these 24 networks. And you can see that we are covering various disease groups here. And the mission of the European reference networks is really to apply existing knowledge, to disseminate knowledge, and to generate new knowledge. So we are generating clinical practice guidelines. We have an online consultation system for difficult cases. And we produce disease information, both for experts that we disseminate in webinars and in a e-learning case format. We also have clinical exchange programs, and we work with Orphanet on the disease descriptions. I'll come back to that in a second. And regarding the knowledge generation, we work a lot with registries that I would like to focus in my presentation. So we are collaborating closely with the Orphanet Institute and the Rare Disease Classification System. They provide the ORPHA codes. So we are in actually constant exchange with Orphanet on updating the diagnosis, the ORPHA codes, to the latest state-of-the-art knowledge regarding pathophysiology, the biology, and the management and outcome of the diseases. And in our network, for instance, the ERCnet, we have about 300 rare kidney diseases listed in the Orphanet system. And we updated about 100 of the disease descriptions that are available online. And we reclassified about 30 disease groups and individual disorders. You may be familiar with the disease organization in the Orphanet, where you have groups and then disorders and subtypes of the disorders according to etiological, clinical, histopathological, and also genetic characteristics. For the rare kidney diseases, we have actually linearized this system to make it applicable in our registry. And I will show you a little bit more on that. So what are the potential uses of ERN registries? Well, we could use information from these large groups of patients. In the ERNs, we are covering altogether approximately 2 million patients in Europe out of the 30 million rare disease patients that live in the European Union. So we can provide demographic information. We can help the diagnostic research for genotype-phenotype association studies, but also we could provide information for diagnostic and prospective biomarker discoveries, trials, and most importantly, perhaps, we can foster clinical therapeutic research by identifying new patients for clinical trials with innovative therapies, by providing external control data, real-world data for clinical trials, and also we can provide real-world evidence on the safety and efficacy of new therapies that are applied in-label or off-label in many of these patients. And finally, we could also contribute to outcomes research and health technology assessment, because we are providing long-term follow-up of our patient and assess the quality and equality of rare disease healthcare in the European states. So the ERNs were started in 2017, and in 2018 and 19, the European Commission called for rare disease registry grants, and we were among the first 5 that received a grant to develop an ERN-wide registry, our ERN. And then in 2019, all the 24 ERNs received funding to develop rare disease registries. Subsequently, we received add-on funding for implementing, rolling out the registries. And since this year, we have indeed structured support that is part of the central budgets of the ERNs. So for the next couple of years, these registries are fully funded, and they are independent of commercial support. So they are basically publicly funded institutions. So in principle, how can we collect registry data? Well, you can do centralized data collection, where the participating sites enter data into a central system, or you can use federated approaches where the data stays where it is, and we are just interrogating local databases in a federated approach. In the ERN registries, we use both of these systems, and you can see here about 2/3 of the registries are using centralized or central systems, and about 1/3 use federated systems. On the right hand panel, you can see here the number of patients currently enrolled. It's a logarithmic scale because when you start establishing a registry, it is kind of hard to get all the administrative and organizational issues done. So it takes quite a long time to get the first patients in. Once you are established, you can achieve quite a good collection of data within a very short period of time. I will show you that. Each registry has approximately 50 to 80 sites that are contributing, but they are intended to contribute. And you can see again here on the right-hand panel that out of the number of sites that we want to enroll, we have only a fraction of patients currently of centers that actually can enroll because they have all their ethical legal paperwork done, and the registries are ready to enroll patients. So it's kind of a cumbersome process that takes a little bit of time. So what data do we collect? Well, all 24 registries indeed collect what we call the common data elements for rare diseases. It's actually 18 very basic features that are collected throughout all registries, such as the date of first diagnosis, for instance, the genetic diagnosis, the consent for the reuse of data, the age of the patient at the current time of death, and so on. So these are very basic data that we are collecting. And of course, the author code is part of it. 21 out of the 24 registries actually are using author codes to code their diagnoses. And then there's 3 hematological and oncological registries that are using particular codes for their diseases. Here you can see the number of data elements collected per registry. So we have, of course, many more individual items collected, more than the 18 common data elements. And on average, in fact, each registry is collecting some 200 to 400 data elements. And these data elements contain clinical features, phenotypic disease features, the genotypes, related items, medication related items, laboratory items, then some do collect intervention information, quality of life, imaging, and patient-reported outcomes. These are the main types of data that we are collecting in these registries. So in our ERN, the rare kidney disease ERN, we have set up what we call the REC registry. It's the European Rare Kidney Disease Registry, and it's a single core registry for all rare kidney diseases. We collect demographic information. We help for the identification of patient cohorts for research, and we do some deep phenotyping and natural history tracking in disease-specific extensions. We call them sub-registries. And we use the registry to monitor clinical management performance and outcomes. And you will see how we do that. Here on the right-hand side, you see that many sites all across Europe are actively entering data. And we managed to enroll now 22,000 patients within the last 4.5 years. So it's quite a big database, and it's continuously growing, adding more than 100 new patients every week. And also we are asking for updates of the patients once a year. And these updates are currently accomplished in about 75% of all patients. You can see how the registry is constructed with the core database to which disease-specific extensions, sub-registries are added. This is the cohorts that we were able to collect by now. You can see that these are actually the 30 most common rare kidney diseases. And for each of these quite rare disorders, we have been able to collect sizable cohorts now. And these are being used for many purposes. We also have a kind of what we call a cohort finder, programmed a module that allows us to identify very easily in the main registry the number and of patients with a certain disease or a certain underlying genetic disorder, and also to break down these cohorts according to age ranges, current treatment modalities, and so on. So that is quite nice to have, and it obviously triggers a lot of research enterprises. So it's a very good resource for clinical trials, but also for observational studies. And this is just to show you how we use this data for standard of care or natural history studies. I took here an example of certain therapy, a C5 inhibitor therapy that is very expensive and not always needed to be administered in this disease for a long time. So here we studied the duration of time, how long these drugs are administered in certain subgroups of the disease. The other thing that we do is really to monitor according to certain key performance indicators that we have defined, our experts have defined in Delphi consensus processes, and that we have implemented in the registry. So we are asking for items that inform these key performance indicators. And now we have a system in place that allows to monitor one's own center's performance with respect to achieving these defined targets relative to the overall ERCnet average. So the centers can benchmark themselves against all others and see how they are performing in relation to them. And that system is being continuously updated. So this is an automated system, and as soon as you save new entries, you will see how the numbers change for a certain disease group and a certain performance indicator of interest. So this has become a very popular feature of our registry, and we are further refining it all the time. And we hope to improve the management quality by creating a kind of friendly competition between the sites to be in the top percentiles. What we also can use these data for is really to benchmark the performance of the individual national healthcare systems in Europe. This is an example of the median turnaround time of genetic screening. This is something we are monitoring in the registry, and you can see that there are some major differences in these lab performance indicators between the European countries, and we encourage our members to take this information to their national authorities to improve the management of care and provision of care for their patients in their individual countries. So I said we encourage them to use this data, and we also encourage interested researchers and other stakeholders to make use of our data. This is the results of a survey we performed among the data access committees of the ERN registries, where we asked them whether they are ready to provide data to different stakeholders and which level of data they are ready to provide. And of course, usually these are individual decisions made by the data access committees, but by and large, the majority of our registry data access committees are ready to share pseudonymized patient-level data, and most of them would share aggregated data, of course, and data accounts. So, and they would be ready to share these data with researchers from within the registry or outside the registry, but also with regulatory health authorities and also industry requesters. Since we consider this a very important part of our work, we try to harmonize the framework, the administrative framework of data sharing by not only using common data elements and verifying the data to make them interoperable, but also by using standardized informed consent forms that we have now provided in all European languages and also in pediatric versions, and also by providing standardized collaboration, data transfer, and data sharing agreements. And we also strive for a harmonized data access policy. So for our registry, data access can be provided through an online form that is freely available. And so requests can be made and will be submitted to the access committee. So what are our current issues and future perspectives? Well, most of the registries are still using manual data entry. And of course, in the digital era, we would really like to use the electronic health records for automated data transfers into the registries. And this is something that a lot of work is now put into to go that next step in the next few years to alleviate the workload with data collection. We also are considering ways to provide access to the patients to their own data, and even to allow patients to curate their own data. We are also looking into the monitoring of patient-reported outcome measures, direct monitoring through digital tools, mobile apps, and so on. These are developments that are also receiving funding in Europe now, public funding, and we are hopeful to make some progress there as well. And then regarding the regulation of data access, of course, we have the GDPR in Europe, and we have to meet the demands of the GDPR regarding the dynamic consent, that a patient should be allowed to modify individually parts of the consent at any time. We also are preparing for what is called the European Health Data Space. Currently, we have a project ongoing, which is called Jardin, the Joint Action for Integration of ERNs into the national healthcare systems, where we are trying to better link the European reference networks, which are primarily transnational structures, to the national healthcare systems where the actual patients are taken care of, and to have the ERN reference sites as the kind of flagship sites or the top referral sites in the national healthcare systems. So with this project that is going to start next year and will run for 3 years, we will interlink the ERNs better to the national healthcare systems. And one piece of the work is indeed also to perform some fundamental work to facilitate the electronic health record data extraction for use in the registries. And the future vision we have in Europe is to have integrated health data space, we call it the EHDS, which is mainly designed to work with national registry data. So in the ERNs, we have transnational data, and we will try to link these ERN registries as well as transplantation and cancer registries with national healthcare data, national registries, to make the data available for various purposes, including regulatory purposes. So this is something a little bit still down the line. This will come in 2 or 3 years. What we currently have worked on in the European Joint Program for Rare Disease Research is we built a kind of integrated platform. We call it the virtual platform, which is a network of federated resources. It allows an integrated access to registry and biobank information, but also to other information in the rare disease space, such as available cell lines and animal models, knowledge bases, data analysis platforms, and so on. And yeah, this is a bit more detailed view of the resources that we are joining in this ecosystem. So it's a kind of service-oriented middleware of interlinked web services. It's distributed and federated by design, and it makes extensive use of pre-existing standards, follows FAIR principles, and adheres to certain quality and sustainability criteria. We have built an access portal, a query builder, where you can indeed enter a disease name or a gene or an offer code, and you will be provided with data elements or lists of data elements from various registries, but also from knowledge bases and repositories of biomaterials or other registries. So this is a kind of integrated access to various resources. Of course, the access is regulated. There is certain features that you can access only on the a very high level, and others that you will have to authorize and authenticate yourself to get access to. And finally, we are launching very soon the European Rare Disease Research Alliance, the ERDERA project, which will integrate rare disease research in Europe over the next 7 to 10 years. This is a multi-million enterprise, and one part of it is the European Clinical Research Network that will have a diagnostic and outcomes research and innovative therapies work stream. And in the outcomes research work stream, we have a real-world data component. And here we will include the ERN registries for outcomes research. We will integrate the data from many of these registries. We will marry the ERN registries with population-based approaches, and we will try to augment data quality towards regulatory grade quality to make these data useful for approval studies for new innovative therapies. Yeah, and this was my last slide. So I hope I gave you a useful overview on the registry use for rare diseases in Europe, and I'll be happy to answer any questions. Thank you.
I have one supplementary question which Ronald may have the answer to, which given that the UK is no longer part of the European Union, are we banned from this network?
Thank you. That's a fascinating question. Ronald Cornet, Amsterdam UMC. Actually, we have recently, in the process of coming to this ERDERA proposal, I think like 2 days before the deadline, there was an announcement that UK parties were able to join as basically full-fledged partners in proposals like these. So while for a few years there have been quite some setbacks for UK organizations, they can now again partner.
Is that part of us contributing to
Yeah, so basically for the European members, this is covered through Horizon, and the affiliate agreements that the UK has made is that basically the UK government, as far as I understand, will compensate for the costs being made by organizations participating in such a proposal. Yeah, so we're gradually closing the gap again between mainland and UK. Yeah.
So the only reason I know this is because we're going through the process at the moment. So that's true for Horizon funding. There's still agreement to be made on Erasmus funding, apparently. Don't ask me why. It just is what it is. So if there are any questions for Franz, can I suggest that you submit them to me and I will email and get a response from Franz for you?
Absolutely.
Okay. So the ones I was thinking of the ones in the room because they've known. So if you're online, obviously, if you type in questions for Franz, we can get an answer for them because Franz is online to answer them. So, shall we move on? So I'd like to introduce our next speaker. Sorry. Okay. So apparently we're fighting over who's going to be presenting it. What do you think? Do you fancy presenting? No, he doesn't seem too keen. I'll come over with you. There's a clicker to take it forwards, and you can obviously see something on the screen. So I'd like to introduce to you Sandy Jones, who's from the Centre for Disease Control, CDC, in Atlanta. And she's going to tell us everything you've ever wanted to know about cancer registries in the United States.
Is it on now? Ah, okay. Thank you. See if I can. All right. So I'm going to start off. I'm going to talk to you about central cancer registries in the United States. Back in 1992, Congress passed the Cancer Registry Amendment Act, which authorized the CDC to fund state cancer registries, to fund states to set up cancer registries that would collect data on all cancers, that would include the type, extent of the disease, and the location of the cancer, along with the initial treatment and outcomes data. This made up, CDC actually funds 46 central cancer registries, are 46 states, the District of Columbia, and 3 territories. This covers about 97% of the US population. And in conjunction with the National Cancer Institute's SEER program, surveillance, end results, and epidemiology program, we have 100% coverage in the US for cancer registries. The data that are produced by the cancer registries are made available for researchers, physicians, policymakers, and public health professionals, as well as the public, to be able to monitor the burden of cancer, as well as to evaluate the success of programs, some of our cancer prevention activities in controlling cancer, and at the national, state, and local level. We actually collect all this data on about 1.8 million cancer cases each year. So it's a lot of data. So just to give a little bit, and I guess I can't. So I'm gonna have to stand over here. I'm having issues. Oh, I can't. Thank you. Problems, I guess. I mean, I might need to. I'm really having eye problems. Okay. So, basically, so cancer registries have several data sources that they collect data at the state level. And the sources include physician offices, pathology laboratories, and medical treatment facilities across the country. They're all kind of dispersed. I am really having trouble with my eyes. Can I put on my glasses? That's so embarrassing, but my contacts are not. Thank you. It's so embarrassing. I should have realized. Whoo, I can see now. It's been a whole day of contacts, right? That are very tired, and so as I was saying,
Case finding is the biggest thing that we do right off, is we have to find all the cases of cancer. There are so many different sources of data, pathology, hospital records, surgical, clinical, facilities, standalone. We also do linkages with death certificates to identify any cases that we may have missed. We have abstractors, cancer tumor registrars that actually are trained through the National Cancer Registrars Association, and they are responsible for compiling all of this information, reviewing it, and actually reporting it and including in our cancer registries at the state level. Calm down. So, the information that is collected in the cancer registries is the patient level, identifiable demographic data, all of the diagnostic and treatment information, as well as stage of the disease. The data is then coded. The tumor registrars, that is one of their primary jobs, is to take the data that comes from all the multiple sources and then compile it and code the data based on ICD-03. As you can imagine, this is a lot of work. We also then have validation of the data, where you may get a different diagnosis from one site, and then you have to actually consolidate and make a determination of which diagnosis is the correct diagnosis. So it becomes a lot of manual work there. We also work with our vital status to get the data updated on their, whether they're alive or not. Case registration and staging, treatment, survival, we do all of those linkages. We follow the cases over time. And then once we compile at the state level, we'll disseminate that at the state level, but they'll also report it to the national level. So this is the current reporting process. As you can see, each data, and actually I'm going to point. So you have a hospital. Hospital is the primary data source for our central cancer registries. And you'll see the EHR system over there. And I got a question in another meeting, why are they separate? Well, in cancer registries, we have found that we were getting underreported cases for hematology, dermatology, urology, those kinds of cases, because in the US we've had a lot of stand-up facilities that all they do is that particular diagnosis. So they're never entering the hospital. So we had to, through some work with the CMS and Office of the National Coordinator, which I'll go through in a minute, we had to set up a system to be able to get data from those standalone clinics. The next primary source of data is the pathology laboratories, because we can get the pathology data faster. And it actually is the primary source for about 90 to 95% of all cases will get a definitive pathology diagnosis immediately. So the state cancer registry has to consolidate all of that data and then de-identify it before it goes to the CDC. It also is reported to the National Cancer Institute. One of the things I do, the Association of Public Health Laboratories is a cloud platform that allows a laboratory or any hospital or health system to be able to report their data according to a standard to their cloud, and then they distribute that data to the appropriate state cancer registries. We have a standard in place for our pathology data, and so we have already started implementing standard pathology reporting through APHL, their AIMS system. So when the data comes into the state cancer registries, we have a standard called NACER, the North American Association of Central Cancer Registries, has an HL7 version 251 message format. This standard has been in use since, well, it was a V2 message at 2.3 is where we started back in the 90s, late 90s. And this has been updated to a 251 ORU message. We actually developed software called eMark Plus, which is electronic mapping, reporting, and coding for electronic pathology reporting. Now, one thing you have to understand is that, you know, the standard, it is a V2 message, and that means, you know, if you aren't very rigid with that, you're going to get all kinds of stuff. The other thing is that it's a narrative, predominantly in the US, we've had narrative pathology reports. However, back in the early 2000s, CDC has worked very closely in a collaborative relationship with the College of American Pathologists to develop the cancer synoptic reports, which are have a unique code for every question and every answer. And so what that means is when when the laboratories are able to implement those, where the pathologist can check off the appropriate diagnosis, histology, primary site, and so on, that information can be immediately mapped to our data systems. So this has really automated a lot of things. However, so over time, we have, the College of American Pathologists was using C keys, which they developed themselves and managed and maintained. However, recently we have worked with SNOMED CT with Dr. Scott Campbell to actually encode all of our CAP checklists with SNOMED codes for both the question and the answer. So the synoptic reports have been implemented. About 60% of all pathologists are using those in the US. However, I found in my work that there are many laboratory vendors that are, instead of sending the discrete data for question and answers, we are getting it in a text blob that they like to throw into an OBX5 field, which makes it's basically a narrative, right? So one of the great things with eMark Plus is we have built an NLP model within eMark. It is a rule-based approach so that it can be modified by the state partners or the laboratories. So if they're trying to identify cases that need to be reported, it will flag them for reportability. So it also has pre and post negation terms in there as well. So it parses the data out. It actually maps the capped C keys to the ICD-03 codes. Cancer registries have always used ICD-0 for their reporting. So we are now actually looking at SNOMED, and with the inclusion of the SNOMED codes in the CAP checklist, we'll be able to store both the SNOMED and the C keys. This is a screenshot of our eMark Plus software. On the right-hand side is the synoptic report, and you don't see any codes because they're hidden in the back end. And the left-hand side is it mapped to the ICD-03 code. So the CTR, the registrar, did not have to do any touching to this case. It was able to just directly map it over. So this is the cancer registries, do not currently use SNOMED CT. So that I wanted to get that out there. Again, I think I've talked about the college implementing synoptic reports within the checklist. as well as, I think one of the other things is to mention SNOMED. We have through the Office of the National Coordinator and some of our meaningful use activities with CMS, the Centers for Medicare and Medicaid Services. We have implemented a standard that is built off of HL7 CDA. And the CDA standard is for the ambulatory providers to be able to report the critical data to our cancer registries. eMark Plus is able to receive the CDA documents as well. It's a separate module. And so we'll get physician data in. It will have SNOMED codes, ICD-10 codes, and so on. And those are then able to be just directly mapped. And we're using the SNOMED to ICDO mappings that are provided. So the key fields, just to highlight the key fields that we really focus on mapping are primary site, histology, and the behavior. So this is actually the FHIR bundle. We actually have also in addition to our HL7V2 IG, we also have developed a FHIR implementation guide for cancer pathology data sharing. And with this, this is a snippet from the FHIR bundle, and the bundle will have both the college CAP, CAPs, electronic cancer checklist, their C keys. Okay, so it's their code, but we'll also have the SNOMED code. So with both of those codes, we're actually going to map to ICDO, but we will also be storing the SNOMED code. So that's the plan going forward as soon as CAP releases those checklists with the synoptic codes. So CDC has been very busy developing what we call our cloud-based computing platform for cancer surveillance. And what that means is we're taking the eMark Plus software and several of our other cancer registry tools that we provide for free out to our states. We're taking them to the web, and then we're setting up mechanisms for the reporters to be able to report directly to the cloud. So it eliminates some of the duplication of effort that's happening across all of our states. We'll also be able to more easily share data from state to state. And then we will also have that data that's coming through right now that are daily feeds from pathology labs. That data will just be directed to our cloud, the cancer surveillance cloud, that everybody will have access to for their state data. But CDC won't be able to see everybody's data. Each state would only see the data that's theirs. And then CDC will compile that data from all 50 states and produce statistics for the nation. One of the things that I would say across the United States is focused on interoperability. And with the Cures Act, there was the push to actually develop an infrastructure that could be utilized across all healthcare systems. So for the data standards, our basic, foundation is, our SNOMEDs, our LOINC, our pathology data right now, we do use LOINC codes. We use LOINC codes for the question part. And for like the attributes of what data is being reported in the V2 message for the like diagnosis, gross description and stuff like that, we are using LOINC codes for that. We will be moving to SNOMED, and we're actually very excited to hear the collaboration between LOINC and SNOMED. So the other thing is just the architecture. I mentioned we have our FHIR IGs. We also have an MedMorph reference architecture, which I'll go into in just a minute. And then you have policy, TEFCA, QHIN, and our health information exchanges. And I'll talk about that too in just a second. But all this coming from the top down. So we're working from the bottom up, but we've got the government helping to push standardization and interoperability. So that has really been a plus. So I want to explain US CDI is the United States core data interoperability. And these are specific data elements with code sets that are defined that all health systems should be using. So there will be certification applied to these healthcare vendors systems. The US core actually is the public health implementation guide for US CDI. So it actually uses HL7 FHIR. Public health libraries, that is specific to public health and some of their data needs. And then M-code is the minimum coding codes for, let's say, minimum cancer oncology data elements. I can't remember, core data, core oncology data elements. And so M-code actually has a variety of data elements and specific standards associated with each, and they have an HL7 FHIR IG as well. So what we in the cancer registry community have done is develop our IG based on all of the national standards, US CDI, where it addresses all the patient demographics. So we're not creating something new. We're also using the public health library where there are data elements that fit for what cancer registries need there. And then M-code, there are only a few that the cancer registries are going to have to define on their own. So the good thing is we are reusing standards that are already being adopted across the country. MedMorph is making electronic data more available for research and public health. And what this means, it is a reference architecture that uses industry standards and technology. And the goal of this is to improve the availability of data electronically and to reduce the burden on the reporters so that it's using automation basically. So the reference architecture, like I said, it uses industry standards. We actually have, it provides a common approach through which the MedMorph reference architecture implementation guide defines. So anybody can pick up that implementation guide and develop the reference architecture that's needed. It really benefits our programs by saving the program's time and effort and reducing the burden and ability to use for multiple use cases. So cancer registries is only one use case in MedMorph. And so if you think about data and think about the reference architecture, you see there's a highway, you build a highway, you have cars that go on the highway, and then you have gasoline. So the cars to be able to go along the highway is the FHIR APIs. So the FHIR APIs help and direct the data that's going on the highway being the infrastructure to get from point A to point B securely, and then the data, the actual structure and content of the data going on that highway. So with MedMorph, the way it works, there's the brain of MedMorph is the Health Data Exchange app, and it sits inside the environment of the health system. So it sits inside of a hospital or physician office, And it monitors the EHR in real time, looking for specific cases that meet the requirements for reporting to cancer registries. And how it does that is the knowledge artifact repository, which sits outside of their environment, provides the implementation guide, what the structure should look like, what the triggers are. And so the codes, SNOMED codes, ICD-10 codes can be used to trigger within the EHR that this case, as soon as a patient is diagnosed, it will automatically pull that case, create the standard FHIR bundle that is defined by the knowledge artifact. And there's a subscription that the cancer registry can sign up and say, I want to, get this data. And the nice thing is that we're reusing what has been done in infectious diseases like COVID and other kinds of health conditions that have been reported through ECR, our electronic case reporting system. So it's reusing the infrastructure with our content. So the cancer pathology data sharing IG, one of the things here is just to mention, it's really leveraging USCDI. It leverages all of the things I mentioned, M-code. It's really focused on getting structured pathology data to the cancer registries, but not just cancer registries, also to the EHR systems. Because in our work with EHRs and reporting data for meaningful use, we found that many times the data are not in the EHR. The pathology data is sitting outside of the EHR as a PDF or in a text somewhere. So this is a diagram that just shows the way MedMorph could work, and we are actually in the middle of a pilot to test this, but it's able to take the College of American Pathologists protocols and then map that into FHIR resources and exchange that data based on a trigger, send that data over to the EHR as well as to the Central Cancer Registry without having to do any manual intervention. TEFCA, I mentioned in the very beginning, TEFCA is something that the Office of the National Coordinator came about with the Cures Act. And TEFCA stands for the Trusted Exchange Framework and Common Agreements. And it is a nationwide network of networks, meaning there are quality health information networks that are in the process of being formed. And it means that a physician's office, an EHR, could be a member of one QHIN, and then another physician's office could be a member of a different QHIN. But if that patient goes from one physician to another and they're on different QHINs, they can exchange data between the QHINs using the standard implementation guides that we've developed. So the Office of the National Coordinator, or ONC, is working with these QHINs that will be identified. They're right now working on all of the specifications that need to be supported, and then they will be implementing these. And CDC is we're seeing ourselves not as a QHIN, but as a member of a QHIN. So all of our state partners would be the same. But if you think about it, if you could see all the QHINs having certain data, they're reporting for ELR, for infectious disease, but you also have for cancer, you have birth defects, you have, heart disease, stroke, so many different things. But if we have it all coordinated, the QHINs, their job will be to coordinate that across. And then just really interoperability is huge for us. I mean, in order to get our data and get good quality data, we need to stop mapping data so much. We need to not have narratives as much. I mean, we know we can't get away from it 100%, but where we can, we need to move towards standard information, discrete data. And working with our vendors, having these standards defined will help our vendors and our reporters understand exactly what we're trying to get. What do we need? What are the rules? And there won't be any, wondering, well, what am I supposed to do? So, and honestly, to get daily feeds, you might not think, I mean, cancer is not an infectious disease, I guess. So, but you really want to get data faster so that we can have better statistics. The NCI and CDC work together to produce the US cancer statistics. There is a visualization tool out there for use. And there also public data sets are made available to researchers and others. You just have to go through a process to get access to that data. And I think the other big thing I want to mention is just that the work I'm doing with the Association of Public Health Laboratories, those laboratories are reporting data daily. And in fact, I just have a genetics laboratory reporting in real time. And one of my states is like, whoa, I don't want to get it real time. So a lot of things to learn and a long way to go, but we've made a lot of progress with our laboratory reporting, with the assistance with the College of American Pathologists, with the assistance from SNOMED, and we're looking forward to getting that data and working with vendors to store the data appropriately so that we can get the data out into our registries to minimize manual work on the coding. And I think that's it. And I apologize for the rough start.
Thanks, Andy.
Now that I can see you,
So,
I have never had that happen.
Thank you so much for this presentation. For everyone online, I'm Sylvia van Laar from the Netherlands. So to clarify, because usually the thing about registries is that it takes ages before the data gets in. So what does, like, everything comes in so fast, or is it like a part, or how
Right
does this
now,
work?
pathology laboratory reporting is becoming more like real time. So as soon as a case is diagnosed, that pathology report can be sent through that infrastructure I talked about, APHL AIMS. It actually can go from the lab. They have it automated. So it has a filter. It identifies the case based on the trigger codes, and we're using ICD-10 right now. But then being able to transmit that data electronically every day to the registries. But you're right, there's other data coming from the physician office isn't quite there yet, but we are working on it with the FHIR implementation guide. We have the CDA implementation guide, and states are receiving that coded data. Some of them, maybe not daily, but, weekly or monthly.
It's quite impressive.
It's just a lot. There's so many pieces to it that we're tackling one piece at a time, so.
Thanks.
And hospitals, I think I want to say hospitals, like I said, were the primary source of data forever. And there is a standard structure called NACER, the NACER record, North American Association of Central Cancer Registry record, that all hospital cancer registries have to report to the states. And there is some concern that they don't want the hospital cancer registries to disappear, because they do a lot of work to track down all the different pieces of information for their patients. So
looking around the room. Victor.
Thank you for a fantastic presentation. You take us through a really nice tour about how to start and how to get to have this thing, this fantastic thing. My question is about the access to their own information for the patients. How do you do that?
Access. So I forgot to mention, all states have legislation in place that mandates the reporting of cancer information. So I forgot to mention that. Yes, all states have legislation in place that public health should be getting all cancer diagnoses. For patient, public health is exempt from HIPAA. Public health is exempt from HIPAA, which there are situations. My son was diagnosed with brain cancer, and I remember getting a question about, can you release your data, blah, blah, blah. And of course I said yes. And if the patient says no, honestly, I don't know if our cancer registries, they really should be sending the data. So it has been a point of question about patient authorization and consent. But the patient, the physician would have to pull those cases out based on their capturing of that consent. But as a parent who lost my baby 3 years ago to brain cancer, I can't imagine a cancer patient not wanting to give their data, to be honest.
Yeah, and I'm sure that is generally true across all health jurisdictions. I've got a rather specific question. So if it's too detailed, just don't bother answering. But I'm interested in whether there's a special process or a special kind of alert for that relatively rare group of cancers, which are cancers of unknown primary, where the starting point was, I have no idea what this is, but maybe somewhere down the track, a diagnosis that is more reliable comes up. How does the registry deal with that kind of issue?
So I am not a registrar, but I will tell you that, so if the case was diagnosed at one time and then they had another, maybe something else came up, both of the diagnoses would go to the registry, and then the registrar would have to figure out how that case would be reported.
Yeah.
And that's just, again, from what I've heard. I don't do that. But that's a hard job, and that's the kind of thing that is very manual.
Well, so I met Sandy yesterday in the pathology block, and what's very clear is that somewhere, and I don't know if they all live in Atlanta or whatever, there must be an army of people on the telephone, either to individual hospitals, maybe even to individual patients, I guess, saying, what happened to you? How did this work?
Yeah.
Because although there's this amazing machine that you've developed and designed that takes data from all sorts of places, the verification of your data flows must be manual at quite a lot of points.
A lot of manual consolidation. We do have a process for automating some of the consolidation, but again, there's still those outlier cases that is going to take manual intervention, and they do have to go back, follow back, they call it follow back, to go back to the source and say, hey, this was coded this way, but then, we've got this, can you help me out here? So, and that's when we also capture the data of who the pathologist was in interpreting the report. And then also we capture as many of the physicians that take part in the case. So.
Yeah, I'm Zulhairi from Malaysia. So just to end on that question, what about one patient but recurrent diagnosis? So how do you deal with that?
Recurrence.
Yeah, meaning within 5 years and
Yeah. There are special rules for that and how they will consider it recurrence, or maybe it was the same cancer that really wasn't gone. I'm not, there's a whole book of rules. The tumor registrars are the knowledge base for that. So some of the rules are very complicated. I can tell you that they're very complicated to determine what's a recurrence and not. And the National Cancer Institute is, they do a lot more with the recurrence. CDC has been more the initial diagnosis and treatment, but that is something, recurrence is something that we are starting to look at as well, I believe. So.
And as you know, it's fiercely complicated for the oncologist looking after the
I
patient,
bet.
let alone for the registry.
Yes.
So one last question, which is a SNOMED question. Who's out there in the American world begging you for SNOMED data?
I don't think anybody's out there begging. I don't think anybody.
That's.
I mean, I don't know that. There's SNOMED codes being used in the EHRs and the physicians' systems. Pathology, not so much. Laboratories don't use SNOMED. Many of them are just now even starting to use LOINC. So, and some of those don't know how to LOINC, but it's hard. I mean, it's not an easy thing. And if you don't have the education on how to assign LOINC codes, then, and we see a lot. But I think the work that the College of American Pathologists has done with the synoptic reports, with all of the pathologists that play a role in the development of those protocols, is really making a big change in cancer pathology. And that's huge. And we do know that the health systems, they do have SNOMED codes there. How good they are and what they're, that's another.
Yeah, well, you have to understand interface terminologies, don't you, in there. So I think that is really interesting. And although this is now, this is a subfraction of the whole group here, I think we should leave this room as kind of evangelicals for SNOMED and talk about those advantages so that people are beginning to beg for that data. Because we know that when a cancer data set is encoded in SNOMED, the things you can do with it, to find new treatments, to find new ways of thinking about the disease, are fantastically more powerful than if you've just got an ICD-0 code. For all the reasons that you were talking about yesterday, which is there's a lot of nothing else specified, not known, et cetera, which you can't compute.
Right. ICD-03, I mean, we've been doing ICD-0 forever. And so by us adding SNOMED as a separate data element, we're hopeful that we can look at that and show how much improved it will be, because ICD-03, we map multiple terms get mapped into one code. So you lose some of that.
The granularity and the attributes, the relationships, all those things that we talk about,
and that's why we're doing
need to turn into a resource. So thank you very much, Sandy. Let's give Sandy another clap. I think Ian is expecting me then to round this session up. And first of all, can I thank the three speakers that are here and the one who may or may not be still online. We really thank you for a brilliant set of presentations and discussions, and some real, I think, messages to take away about the value of aggregating data from the individual patient to a whole cohort of patients or a whole population of people, actually, because we're all at risk of disease sometimes in our lives. And being able to predict some of that, predict things that'll be effective, interventions that might prevent the development of that disease in the medium to longer term is the aim of what we should be doing, so that we can close all the hospitals and everybody can stay at home and stay well. I mean, that may be a bit of a dream, but some of it's possible. You know, COVID was an example of that. If you stayed home, you didn't get COVID. But that doesn't work either, because you run out of money, you run out of all the things that make life possible. So understanding how those processes work by collecting data is, I think, the challenge for us. And as I say, we need to go out there, evangelize, proselytize the ways to do this effectively with data. So our responsibility is to understand SNOMED even better than we currently do. And it's difficult to understand SNOMED, I think. It's not, you know, you've got to put your brain to it. You've got to go home and do a bit of homework. And you have to think how I might persuade that army of nurses and doctors and therapists and so on to use the systems that healthcare delivery agencies, whether that's that funny little EHR that just looks after one sort of cancer somewhere in America, right through to the massive hospitals that most of us get involved in, to use those systems to collect the granular detail that you need using structured data in an information model that it can understand. And certainly my experience in England, at least, is persuading people of my age or a bit younger to unlearn what they learned about taking a history and to reform it into problem listing and so on, even though that was described, I don't know, 70, 80 years ago by Larry Weed. It's still not done. It's still recorded in free text. And, but I think we've heard this afternoon what you can do with data, which is granular, which is structured, and how you can benefit society by creating data assets, which are then available more or less to anybody, because you can de-identify that data, for really productive research and learning. So I'm going to leave it there and end by thanking you all for sticking it out and thinking with us and contributing and so on. And one of the weirdnesses of modern meetings is it's not finished here, because Ian still has his computer open and you can send us questions, send us thoughts, send us ideas about what to do next, whether that's just setting up the next meeting, making a suggestion for what a clinical afternoon like this should feel like, because this meeting is always, it's probably, I think, the 5th or 6th time Ian and I have hosted a clinical meeting, and they're profoundly different to the rest of the SNOMED sessions, in my view. And you may think, well, it's a waste of time, or you may think they're great, but whatever you think, we'd like to hear about it. So thank you very much and see you next time.